As soon as you sign up for a patient in the Edis, it initiates an assessment code. An assessment code will automatically be placed in the billing table. If you click on the acronym ASMT for assessment codes, it will bring a pull-down menu showing all your assessment code options. These assessment code options should be familiar to you as they are the same assessment codes that you've seen in the top left corner of our pink billing sheet. You must pick one assessment code for every patient that you see in the emergency department. Just like in the pink sheet, these assessment codes are mutually exclusive, and every patient must have just one type of assessment code. I'm going to demonstrate in detail a simple case of a laceration repair. This example will illustrate how documentation on the Edis is linked to billing. In subsequent examples, I will put little emphasis on documentation and mainly focus on the billing components. Once you've signed up for a patient, you want to go to MD Notes and then click on the H&P template and pick the most appropriate template. For this example, we're going to use the basic template. As soon as you pick an H&P template, the nurse's note will pop down into the MD Note for your review. You can then go down and document your history and physical in the MD Note. You can click on Plan and pick some of the pre-canned options, or just free text what you plan to do. To document results and procedures, just click back on the MD Notes tab and a new MD Note will be dropped. To document your X-ray results, just click on the MD Note, scroll up to ERP test results, and then click on X-ray interpretation. Then just free text your interpretation of the X-ray. I'd like to emphasize that it's really important to try to document your procedures through the canned procedure notes through MD Note. Using the canned notes will generate billings automatically. Although you can free text all of your procedures, this will not generate any automatic billings, and you'll have to go to the billing table and enter all of your billings manually. To document a procedure with the canned notes, click on MD Note and go down to Procedures. It will generate a list that contains 99.5% of the procedures that we do. They are organized alphabetically, and you will need to become familiar with the list in order to access the procedure codes rapidly. For this example, we pick Laceration Repair. A pre-canned note will be dropped into the medical record. Click on the underlined blue words to make the note specific to your patient. Note that the laceration type that you pick will determine what code is billed in the billing table. In this example, a simple laceration that's less than 5 centimeters. You can specify the specific location of the laceration and also specify the method of closure. You can also pick the number of sutures and type of sutures, as well as the type of local anesthetic used. To document your discharge instructions, just click on the Discharge Treatment tab and scroll down to the Patient Care Instructions. Here, you can either free text or pick from a series of canned notes. For this example, we pick Suture Care Routine, and we can specify what day we want the sutures to come out. Finally, we want to review the billings that we've generated from this patient encounter. Click on the Billing tab to bring up the billing table. You'll see that the Z176 laceration code has already been dumped in the billing table because you used a canned procedure note. You must also pick an assessment code by clicking on the ASMT, bringing up the pull-down menu, and in this example, clicking Multiple. This will generate your H103 code. Now, I need to bill these codes to a physician. Go to the Bill To column and enter the physician's name that's responsible for the billings. In this case, me. Every code documented must be billed to a physician. If I right-click where my name is, I can copy my name into all other billings in the billing table. Now the chart is ready to be signed off. I go to MD Disposition, pick Discharge, and then select Discharge Diagnosis. Now I can click my name to sign off the chart, and the chart can be removed from the track. You won't be able to digitally sign the chart unless the billing table is completed. The rest of the examples in this video are going to focus on billing only. This case involves reducing a fracture with a second physician giving procedural sedation. As usual, you document your normal history and physical examination. In this case, you've diagnosed a lateral malleolar Weber B type ankle fracture that needs reduction. To document your reduction, go to MD Note, scroll down to Procedures, and click on Fracture Reduction. In the CAN note, you can pick the type of fracture, in this case ankle. You can then free text in how you immobilized it, and if you arranged for orthopedic follow-up or not. If you did arrange for orthopedic follow-up, the fracture code will be prorated to 75%. For procedural sedation, you'll find in your fracture reduction CAN note that one of the options for your analgesia is procedural sedation. In fact, it's the default. Be aware that clicking procedural sedation in your fracture reduction CAN note does not initiate procedural sedation billings. To document your procedural sedation, drop a new MD note, pick Procedures, and go down to Procedural Sedation. Document the details of your sedation. Then go to the Billing tab. You'll see that procedural sedation has been added to the billing table. Click on Procedural Sedation, go down and pick Proc Sedation. You'll then be prompted to pick the procedure that you provided sedation for. You then pick whether you sedated the patient, then pick the number of basic units for the procedure. For the most part in Emerge, almost all procedures are 6 units. Enter the time that you started and stopped the sedation, and the billing clerk will calculate the number of time units. Click any special premiums, such as a large BMI, and finally, click on any time premiums. If you hover the cursor over Proc Sedation in the second column, it will summarize all the details you just entered. Now, before we sign off the chart, we must pick an assessment code, in this case again, a multiple or H103. You'll see the fracture code has already been prorated at 75% because we've arranged for orthopedic follow-up. I initially assigned all the billings to myself, but then realized it was my colleague Ken Edwards who actually did the sedation. In order to change this, I just have to go over to the column that says Perform By and change that entry to Ken Edwards, and then also add Ken's name to the Build To box. Note that Ken didn't even have to sign into the chart for this, I could bill it for him. Now the chart's ready to be signed off. In this next example, I'm going to use a sick, ruptured AAA patient to illustrate how to bill for ultrasounds and also to bill for critical care codes with 2 or more physicians. This patient was readily identified as being sick, and a history and physical template was dropped and completed. A bedside ultrasound was performed and was documented by clicking on MD Note and then scrolling to ERP test results and then going down to ED ultrasound. This drops a canned ED ultrasound note, and now you can pick the ultrasound type as well as the results. In this case, we found an 8 cm AAA. You'll see in the billing table that this has generated an H100 code. Now for the assessment codes, we had 2 physicians involved. The first physician clicks Assessment and then goes down to Critical Care Major. You'll then be prompted to identify which physician number you are in the resuscitation. In this case, I'm physician number 1. Then you'll be prompted to enter your start and stop times in the resuscitation. The billing clerk will determine the number of 15-minute interval G codes that you'll bill for. For the second physician, you'll need to initiate another assessment code. Just enter ASMT, and this will bring you to the assessment code list. Scroll down to Critical Care Major. This physician should identify his or herself as physician number 2, and then enter his or her start and stop times as before. For the Performed By and Billed To columns, I would need to change the second assessment codes to the physician that was involved. Again, I could do this for my colleague without them having to sign into the chart. In order to illustrate how to use some reassessment codes and some forms, I'm going to use the example of a vague elderly woman with some chest pain that ends up requiring serial enzymes and subsequent CCAC referral. As in previous examples, drop and complete a history and physical template. This woman had blood work, troponins, and an EKG done. When these came back, she was reassessed. To document a reassessment note, I had to click on the MD Notes tab, and that would drop a new MD Note prompt in the medical record. If I click on MD Note, I can go down to Progress Notes, and then click on Reassessment Note. This will dump an H104 in the billing table. I can document the time of my reassessment in the canned reassessment note. As well, I free text what my next plan of action is. I can document my interpretation of her ECG by going to MD Note, then ERP test results, then ECG interpretation. I then write what my interpretation of the ECG is, in this case, normal. I've decided I need to do another set of enzymes and a cardiogram on this patient in another 2 hours. After these are back, I can document another reassessment note. The times in your reassessments should be at least 2 hours apart. We will use the times that you've documented in your reassessment note, not the timestamps that occur automatically. I've determined that this patient has no acute medical problem going on, but is unable to go home at this point in time and is in need of CCAC supports. I want to bill for a CCAC referral and for overnight holding orders. If I go to MD Notes, I can go to Forms and then to CCAC Referral to drop in a CCAC referral note and billing code. Similarly, if I go to MD Note and then to Progress Notes, I can pick Holding Orders. This will document that I wrote overnight holding orders and also generate a new code in the billing table. Now, if I look at my summary of billings for this patient, I have to pick an assessment code, and in this case, for sure it's going to be an H102. You'll see my billing table has already been populated with 2 reassessment codes and a CCAC referral form K070 and some overnight holding orders H105. ECG Billings. I know this is an area of controversy, and I believe the majority of our group are not comfortable with billing ECGs. If you document your ECG interpretation through the MD Notes, it will generate a billing code in the billing box. Note, however, that the code says MD Verify. This means that the physician must actively write the word bill in additional info beside the code in order for it to be billed. The default will be that the code is not submitted. There are some additional billing codes that you need to be aware of that aren't generated through MD Notes. You can find these by going to the billing table and typing in AB for additional billing. This is how you'll indicate to the billing clerk when you're on call. When you're on call, try to remember to go to the billing table and type in AB, go down to On Call, and add this to all of your billings. That way the billing clerk can add the travel and special visit premiums to all of your codes. Similarly, if you're involved in a trauma with an ISS of more than 15 in an adult or more than 12 in a child, click on AB and Trauma with High ISS. This will add a 50% premium to all your codes. Now, I understand there will be people that want to free text all of their documentation. This is not recommended as it will not automate any of your billings. However, it's important to show you how you would enter billings directly in the billing table that are not generated from MD Notes. All of the codes are organized by prefixes. If you click on the prefix key in the billing table, it will show you all the categories of billing codes. The multicolored pocket billing sheet that I've created mirrors the organization of the codes exactly. You can use the pocket card as a quick reference to billing codes if desired. A PDF of this card is always available through the links in the Edis. If I wanted to directly bill for a fractured ankle, I could enter the prefix FX for fracture in the billing description column. This would show me a list of all the fracture codes. I could then search through and pick ankle reduced. It will then prompt me whether or not I want orthopedic follow-up. If I do, it will prorate the fracture code to 75%. Alternatively, if I knew that the fracture code was F075 from the billing card or from my memory, I could simply enter it directly in the billing code column. If you ever run into the situation where you want to document a procedure and you don't know what the procedure code is, you can always enter OTH for other procedure in the billing description column and then describe the procedure briefly in the additional information column. Then I or the billing clerk can look up the code. Another quick way to put your billings directly into the billing table is to use the billing buckets that are located at the bottom left of the billing table. These are buckets of some of our most commonly used billing codes. If I click on FB, a short list of all of our foreign body codes will pop up, and I can click on whatever one I want. If I click on EENT, a short list of the eyes, ears, nose, and throat procedures that we commonly use will flip up. You'll see similar buckets for fractures, dislocations, lacerations, and INDs. Again, you won't need these if you're documenting your procedures with the canned procedure notes. However, they are a rapid-fire way to grab your codes if you're not using the procedure notes. Just a few points to summarize. Remember, all patients require an assessment code. You won't be able to sign off the chart until you've selected an assessment code. Use the canned procedure notes. If you do this, your billing will happen automatically. If you plan on being a complete free texter, I think you're at high risk of missing codes. You have to sign off your billings before you can sign off the chart. Every billing that's generated in the billing table has to have a physician attributed to it. We've tried to be complete by putting as many billing codes as we could in the Edis. However, it doesn't contain the entire schedule of benefits. If you've done a procedure and you can't find the code for it, feel free to write "other procedure" in the billing description and briefly describe what you did in the additional information column. We'll look up the code for you. Finally, the Edis billing program has far more codes than I've demonstrated during this short video. I hope the video has demonstrated how the billing codes are organized and will give you an approach to sort through all the other codes that you're used to using. As well, we've tried to troubleshoot billing scenarios extensively. If you encounter scenarios that you don't know how to bill, or if you run into glitches in the program, please don't hesitate to let me know.